Welcome to this Beyond Zero e-learning module. This is one of the catch-up sessions for the Wits RHI Advanced HIV and TB training. This particular session is on PMTCT and forms part of the PMTCT series. And this is the third in that series, looking at monitoring and managing the viral load in pregnancy. So as we know, there are many prongs to prevention of mother-to-child transmission, and all of them certainly have an important role. But if one had to pick one key aspect of preventing children from getting HIV, it would be the focus on making sure that by the time the mommy delivers, that her viral load is suppressed. And therefore, when we speak about the single most important thing we need to do during the pregnancy of a woman with HIV, it's about monitoring that viral load. And managing this viral load well can have a dramatic effect on our prevention of mother-to-child transmission. So let's just go back to basics. So the first scenario you might have of a woman that's just fallen pregnant may be somebody that's been already on ARVs. They've said, yeah, ARVs more than 3 months. Pretty much it could be anybody who's on ARVs. But 3 months gives you an idea of, at that point, you would expect the ARVs to be working. If the woman is not yet on ARVs for 3 months, you'll probably wait till she's been on ARVs for 3 months before you do your viral load. But basically, on that day when you just find out that she's pregnant, a viral load must be done. And it doesn't matter if the last viral load was a month ago or 6 weeks ago. Don't sweat about it. Do a viral load as soon as you discover that she is pregnant. And very important is to make sure that we get those results back and get them back quickly. It doesn't help if you do a viral load and you don't know what the result is. So make sure to bring her back and make sure that she sees you on that day. So if the viral load comes back and now the viral load is suppressed, and in this scenario, we would actually say if the viral load is under 1,000, we would be happy to keep her on the current regimen. And if she's not yet on the fixed dose combination and she's on a first-line ART regimen, we can also at this stage switch her to the 1 tablet a day, the tenofovir FTC and efavirenz. Please note, not for second-line patients. If they're on a Kaletra-based regimen, you're not going to be switching back to the FTC. And of course, part of this is now to have a real heart-to-heart with the mom. Now that she's pregnant, there's the risk of mother-to-child transmission and the incredible importance of the ARVs in pregnancy, and also the safety of the ARVs, as this might be a concern. But let's say we've got a mom, as you know, all pregnant women now, we are testing them regularly, and therefore we do have moms that we diagnose for HIV for the first time while they are pregnant. And as per our guidelines, we will be starting those moms on the very same day on ARVs. And for them, the first viral load will be done 3 months later after ART initiation. And again, we do not want to miss that threshold. And we're using 3 months because we assume by then the viral load will be suppressed. And we want to confirm that the ARVs are working and that she's taking them. Again, no point in doing a viral load if you don't look at the results very quickly, and you want to make sure you bring her back in 2 weeks and see what that result is. Our whole focus is we want to know if this woman is suppressing on ART, and we want to know that as soon as possible. So let's say now the viral load result comes back. It doesn't matter if it's a woman who's been on ARVs for a while or if it's now a woman that you've just put on ARVs 3 months ago. If the viral load is less than 1,000, then after that we will repeat the viral load 6 monthly. So notice that's a bit more frequent than you would for your adults who is not pregnant. And so if you've just done your viral load at 3 months, you're going to do another viral load at 6 months on ART, and after that you will do a viral load every 6 months. So 1 year on ART, 18 months on ART, 24 months on ART. And this is the assumption that every single time that viral load is under 1,000. Always look very quickly to make sure you have the results of the viral loads, and very important that these viral loads must be recorded in the maternity record. So the midwife, on the night that the mom delivers, has to make a decision about the post-exposure prophylaxis of that baby, and they will make that decision depending on the viral load. It doesn't help you've written the viral load into the adult clinical record of the mother and you've not put it in the maternity record, because the nurse is not going to be able to access that in the middle of the night. So get your results back and record your results in a place where they'll be able to easily be accessed. But also we are not bound to this particular rate. This is the least frequent we must do the viral load. But if you have a patient who you're concerned something has changed, or you're just looking at that viral load and it's 900 and you're not particularly happy with that, you can certainly repeat the viral load more frequently at times when you may be concerned. But now let's take the scenario, and this is the one that can cause headaches, where you've done your viral load, she's been on ARVs for more than 3 months, and the viral load is more than 1,000. Now, if you've watched our presentation on the managing of patients with virological failure, both in adults and children, you will know about the ABCD, and that it is just as relevant for your pregnant woman. So any pregnant woman with a viral load over 1,000, your assessment is going to include ABCD. The A obviously stands for adherence. So we know to check for things like side effects, to check for concerns, to check for disclosure, to check for all the issues that might be affecting adherence. But very important also in pregnant women to remember both depression and substance abuse as contributing factors. And you have to screen specifically for depression. Your mommy is not necessarily going to tell you that she's not coping. The B stands for bugs, which is our abbreviation of opportunistic infections or any other illness that might interfere with her taking her treatment. So that includes malabsorption. But in your pregnant woman, there's a higher risk of STIs. So remember, she's been having unprotected sex. That's why she's pregnant. And there's also therefore a higher risk of infections. And we need to check for those infections and treat them actively. We're obviously also going to screen for TB. And we're also going to ask about pregnancy-related challenges, such as she might be vomiting or she might be nauseous, she might be struggling to swallow the tablets. C stands for correct dose, very key with our children and very key in our renal patients. Most of our pregnant women would hopefully not have renal problems, and you would have to discuss dose adjustments with those patients as you can't use your normal formulas. And then D stands for drug interactions, and pregnant women, just like anybody else, might be helping themselves to various things over the counter. A classic problem might be heartburn, a common problem in pregnancy. She might be picking something up from the pharmacy, and if you're taking antacids at the same time as your ARVs, it might very well be interfering. Ask about traditional medicines, look at what else you are prescribing. So the ABCD is a very nice structured way to look at all the factors that might be contributing to that viral load be over 1,000. Write them down in the notes, and I would actually write these in the maternity record, all the issues that we are addressing, so that you can follow up again on them when you see her in the future. So the next step is we've done our ABCD, we've explained to the mom that we now have to find out, does her treatment still work? And to do this, we're going to do intensive adherence counseling. We're going to tell her that we need to do a trial, giving her tablets and making sure she takes her tablets well, so that we can see if the tablets are still working. And the viral load will therefore be repeated, and in pregnant women, we're going to repeat it after 1 month. Very important. 2 months is going to waste too much time. To also help create less delays, when you do your next viral load, already take your baseline bloods for your second line. And important there is your hepatitis B serum antigen. The others, probably not too essential to have them back, but you need to know about hepatitis B to be able to make a decision about the tenofovir. You're also going to take either a HB, if there's AZT in a second line regimen, which most of them will be. Occasionally, you might be using tenofovir in the second line regimen if she was on D4T, and then you would take a creatinine for that. Notice small difference here. We are not taking triglycerides and cholesterol, and that is because it is not reliable and does not give reliable values in pregnancy. But certainly the cholesterol and triglycerides will have to be followed up after the pregnancy. And so once she comes back a month later, we now want to see, is the ARVs working? And the way we will know the ARV is working is if that viral load drops by more than 1 log. So antivirals are extremely effective drugs at getting our viral loads down, and we want to see a very dramatic reduction. If we see that the viral load is now dropped beautifully, it's now undetectable, or it's dropping more than a log, and we're quite comfortable that she's taking a treatment and the treatment is working, then you can repeat the viral load in 6 months' time. But you can also do it sooner if there are concerns about adherence or you're a little bit nervous that it's not reliable. But what happens now, they come, you do that second viral load, and now you notice that the viral load is increased or there's less than a log drop. And we wouldn't hesitate in the scenarios in a pregnant woman. We would switch to second line. So if she's saying, well, I took my tablets, and while she was taking her tablets, it did not have an effect on the viral load, we certainly wouldn't want to cause any further delays. And so we would use our normal second line regimen as per the adult guidelines. For most of our moms, that will be AZT, 3TC, and lopinavir ritonavir. And before you switch, remember you have to check your hepatitis B serum antigen result. Hopefully you'd already done that. And if she's hepatitis B negative, you can give that normal 3-drug second line regimen. But if she's hepatitis B positive, we're actually going to use a 4-drug second line regimen. You're going to be adding tenofovir to the existing AZT, 3TC, lopinavir ritonavir regimen. Also important, if the mommy is HIV, hepatitis B positive, that's also putting the infant to risk. And therefore, the infant needs to receive hepatitis B immunoglobulin and hepatitis B immunization at birth. And it's discussed in one of our cases under the abdominal section. If you've got a woman who's already on second line or even already on third line and they're not suppressing, it's very important to discuss those patients early in the pregnancy already with a consultant, where they can make decisions about either genotyping or what else needs to happen to help protect that baby. It might be good just to have a few slides and make sure you feel completely confident in log drops. As you can see here, if you look at the numbers can be a bit overwhelming. So this lady had a viral load of 433,000 that dropped to 9,550. And you can see the log drop from 5.64 to 3.98. So that's what we expect to see with over a month period. Very important when you do compare your viral loads, do look at the dates and make sure that it's 1 log per month. So if it was 2 months that this viral load was taken, if the second viral load was 2 months ago, that viral load drop would actually not be enough. Another example of a good viral load drop from 5.99 to 4.43. You can see it's gone from 967,000 to 27,000, and it is really that dramatic that the viral load comes down. But here's one where the viral load dropped from 127,000 to 88,000, and on the surface that could look quite impressive. But 5.10 to 4.95 is hardly a change at all. And we would say that any log drop less than 0.5 is actually insignificant. That's pure chance. It has no reality due to it. The next viral load might very well be 133,000. And the last one here shows just over 0.5 drop from 5373 to 1618. The temptation with it would be with a case like this to think, oh, look, it's almost under 1,000. But this is actually quite a typical way in which resistance would present, that although they're taking the treatment well, the treatment doesn't drop more than a log, and it hovers sort of in the low thousands. And this would be a priority for getting changed onto second line so we can get that viral load completely suppressed. So in summary, if you have a viral load that's more than 1,000 in a pregnant woman, that is considered an emergency. And you're very simply going to do your ABCD. You're going to address the issues. There's a very good 3 modules on adherence and how you address adherence issues, especially in patients who are failing on ARVs. Then you'll repeat your viral load and your baseline bloods for second line in 1 month's time. And if the viral load did not drop, you're going to change to second line. So all along, you're going to be proactive because that clock is ticking towards labor. Very important, whatever you find or whatever you do during the antenatal time, make sure you record that clearly in the maternal record to help your midwife make a good decision on the night of the delivery. Thank you.